Good afternoon, good morning, and good evening to all of you. I have no interest to disclose. Thank you to the organizers for inviting me to talk today, and more importantly, to put a spotlight on community interventions. I'm here to talk about community data matters with a special focus on community-led monitoring. Before I get started, though, I want to acknowledge the incredible work of our team, and although I'm standing here as one person, I am presenting the sum of work that was done by many people, including several national networks, community partners, as supported by our donors and staff. This slide gives due credit to the pictures used in our presentations. So the story for us starts at the point of need. At clinics around the globe, people diligently queue or line up to pick up their life-saving medicines, only to be told to come back tomorrow as there is a stockout. The important thing to note here is that this is not a one-time story. This was happening frequently and for many different medicines across the globe. And in fact, it would be remiss of me not to mention what's happening in India right now. Indian activists who should be here are not here because they are on the 12th day of indefinite protests for ARV stockouts that are due to bureaucratic delays on tenders with no sign of a solution. What is the Indian government doing? What are UNAIDS, WHO, and the IAS doing to bring attention to this problem? Like in India, in true spirited community fashion, people living with HIV took pen to paper to track their lived experiences out of a need to survive. They wrote their name on missing medicine. They wrote the name of the missing medicine, the day it was out of stock, and the day it was back in stock. Many sheets of paper turned into pill counting projects, which grew into treatment observatories that provided evidence of issues which could be used for solution mining and targeted action. Empty shelves led to community innovations. Necessity bore the fruit of innovation. All too often, we think of new pills, injectables, or some new gadget as innovations in health, leaving accountability interventions around service delivery further from the mind. Community-led monitoring is a global health innovation which is necessary, valuable, and reliable. So what is CLM? What exactly is it? CLM is best understood in the context of the wider range of interventions that are led by communities, such as community-led research, community-led advocacy, and citizen science, which you can learn about in the link below on the slides when you get them. And here you can see CLM is one among the many avenues for community data to contribute to the whole data picture in the global HIV landscape. However, it is important to note that the communities that generate this data rely on systems to support both at the local level and at the wider systems level. CLM must be understood in the context of community systems, which is often an invisible part, an underinvested part of the broader public health system. So what is this thing called CLM? I've learned the hard way that it's very important to explain what it is not. CLM is not community-based monitoring, which focuses on where people are. It is not the monitoring of people by governments. It's not providers carrying out monitoring projects with the support of recipients of care, nor is it a parallel M&E system or covering data collection gaps for donor M&E. It is not data collection only. It is not a snapshot or cross-sectional data, and neither is it QI. In fact, community-led monitoring is just that. It is led by communities. Its focus is on who is leading the work. It is the monitoring of services by communities where they are the end users. So we should end the debate about how can communities monitor community provided services. Where you are the end user, you should hold whomever that is to account. The same data should be measured over time. You should monitor indicators that are relevant to communities in order to improve services, and monitoring that provides an evidence base for advocacy. So community-led monitoring, itself defined, is a process where communities take the lead to routinely monitor an issue that matters to them. Communities then work alongside policymakers to co-create solutions to the problems they have identified, and when you don't listen, we protest. ITPC's community-led monitoring model is seen here. It starts with education. We have to start with education. Communities have to be knowledgeable of and updated on the science behind the disease and normative guidance that govern the standard of care that they should expect. From here, we move into evidence collection, advocacy, and engagement. It's important for me to be able to show that CLM is a model. CLM is not HIV model, CLM is a model. You can apply it in different contexts, to different diseases, to different areas, to other things that are relevant to what matters to communities. So here you see it in HCV, COVID, tuberculosis, human rights, and HIV prevention as well. So at the risk of oversimplification, I am showing you a view of CLM in 6 steps. You're starting here with a need analysis, indicator selection, moving into data analysis with periodic quality checks that is often done in collaboration with an academic institution or a proxy so that there is scientific rigor on the data. Then there is insight harvesting, and then there is some discussion around what does it mean and what are the advocacy priorities to move into targeted action or change. So it is a full methodology. If I had put a slide up here on the steps for a randomized control trial and jumped straight to data collection, you would think that I am insane. So let's not do that. The focus has been on this yellow box. Everybody wants to get an indicator in and they want to analyze the data. No one wants to use it and no one wants to actually understand the gap or where the community pain point was. So removing any one part of these 6 steps effectively means that you're not truly doing CLM. So let's get to the data, and obviously the time is running fast. So here we have a 2018 Regional Community Treatment Observatory. It was the landmark project by the Global Fund. This observatory project was led by 11 PLHIV networks listed here. I want you to see the networks. This was not some other group that was doing the work. This is a snapshot of the data set, and you'll see here that from the top row, all the things that you would like to see decreased, such as the frequency of ART stockouts, etc., have all decreased over periods of time in the monitored sites. And for those things that you want to see increase, such as the quality of care and viral load test performance, and even viral suppression, we were able to see those things increase over the period of time in the monitored sites, therefore attributing some of that to CLM. This is a more recent project, a citizen science project, which focused on HIV and COVID and 1 year of continuous monitoring. And you will see here, before I jump into the data, I really wanted to put a focus on who is collecting the data, because you hear about CLM, but you don't really always understand. So 40 out of our 58 data collectors are from key and vulnerable populations, thereby enabling reduction in stigma and sensitization is increased. Who asked the question really matters, because here we are moving from this paradigm of data extraction really to one of data democracy. So we're going to pop into the good. So what good happened with COVID? So we saw an expansion of multi-month dispensing of ART at our 15 monitored sites in Malawi. In fact, if you look at the dark purple, the 6-month ART dispensing grew from 6% before COVID to 31% during COVID. This is all excellent to note, but is also equally important that you could see this in the Rachidze data as well, thereby seeing how this data is complementary. Rachidze is a CLM project that is in South Africa, which is one of the largest, and they were able to see similar kinds of data. And more importantly, communities are often at the head of the pack when it comes to what should be measured in the global data conversation, due to the fact that it is about their lived experiences. We started collecting data in September 2020, and thankfully, but belatedly, UNAIDS added this brand new indicator in February 2022. We also see what's happening here. Our multi-month dispensing data shows that the main factor in delaying further scale-up of 6-month MMD is not whether stockouts occurred, but rather how quickly they were resolved. So some of the bad, I don't think anybody will be surprised to see that there was heightened stigma and discrimination, but as experienced by recipients of care, key populations, and healthcare workers as being the ones who are actually spreading COVID. We also looked at viral load monitoring. Before the pandemic, 23% of viral load test results in our 15 monitored sites in Malawi took more than 3 months to be returned, so that's that orange color there, to the recipient of care. I did not say to the clinic, because this is an indicator that matters to the community. And during COVID-19, this figure rose to 39%. We also saw limited access to HIV testing services, with the greatest testing amount being among female sex workers. It fell by almost 80%. We saw spikes in teenage pregnancies. If you look here, the highest number of live births to teenage mothers was in April 2021 with an N of 69, which follows exactly 9 months after the peak of South Africa's first wave in July 2020. We also see key findings from the Ruchize data with respect to key populations. 20% of key populations were no longer accessing healthcare anywhere, often due to ill treatment and openly hostile clinic staff. So all of this, what are we saying? It is really a key point to see that the ability of CLM data to influence national resource mobilization processes. In South Africa, for example, the Global Fund data methodology explicitly referenced in the Global Fund, the CLM data was explicitly referenced and was helped to rationalize a 5-fold increase. And then in PEPFAR, we were able to see in Malawi an increased funding for viral load testing, including additional sites to speed up the turnaround time to no more than 14 days. We also see here the importance of applying CLM and community engagement. And because I'm limited on time, I'm just going to run through the rest of these data slides. In Sierra Leone, there was no data for this treatment failure indicator, and they were able to capture that and be able to get a commitment from the NACP to have this as a new data capture. And then in Côte d'Ivoire, which is our sort of very hallmark thing that happened at the COP sessions, where CLM data was able to prevent the user fees from continuing when a circular was issued when they presented their data. We have an ITPC CLM hub launch that will be happening in the Global Village around 6 o'clock. And these are other resources that you can go to. In the orange, we have some peer-reviewed articles and other key resources, including Ruchize, Health Gap, AMFAR, UNAIDS, the Global Fund, and the French 5%. So these are my closing thoughts. I know many of you sitting here are clinicians and academics, and you may be wondering, okay, so all this is great, but how do you isolate the effect of CLM itself? Where's your counterfactual, and what will happen if you didn't do it? So given that there is little to no funding in this field of research, we luckily have been able to find one paper, though not perfect, to compare and addressing the impact of COVID-19 on TB and HIV programs, both in Malawi around the same time period. And our CLM intervention likely had a positive effect on mitigating the negative impact of COVID-19, translating into about 10,000 more HIV tests monitored sites. So I'm going to skip to the challenges. The nature of what is being scaled is varying. We need to accommodate donor indicators, but still find ones that are relevant to the community. We have sustainability concerns because we do not have a refined value proposition, because we don't know exactly how much it costs, we don't know what effective monitoring exactly is, and who is best placed to do this. So the field really needs much more investment and research. And the main problem, I think, is that we have improved, but we're still skeptical about community role beyond advocacy and demand creation, leading to an undervaluing of community data and, by extension, CLM. If we think about traditional academic research outputs, all the studies in the peer-reviewed journal articles that we will quote here, we are compelled to act on it because it is valued. And it is valued because it is valid. We know that it uses rigorous scientific methods that we trust and is able to live in this world of legitimacy because we invest in them. As an example, in 2020 alone, global investment in PrEP clinical research and development was 107 million. If you look at this pyramid, what kind of investment is CLM sitting on? What kind of investment are community interventions sitting on? Did we not hear Dr. Fauci yesterday when he asked the question, if he had to go back in time and do it all over again, what would he do differently? And he said, engage community. We are still only engaged to sit at the table, but with no vote, we get peanuts for resources. And in 2022, we still can't even track how much money goes to community investments because we claim we don't have a clear definition of what a community is. How are we going to ensure that the high-level commitment on at least 30% of all service delivery by 2030 is community-led? And then you wonder why we show up like this. Really, we have to do better. We are this and more. We get to this point because you do not hear us. Martin Luther King Jr. said that the riot is the language of the unheard, and it is often that we feel like we have no voice, like you are deaf as a response. So we have to take the stage, we have to protest. But is it that we are really voiceless or unheard? It might be more that we are deliberately silenced or preferably unheard. There's no more powerful way to drive home the point of the danger of an incomplete story than looking at the progress towards the 95s. For example, according to the UNAIDS estimates in Zimbabwe, these yellow bars show a story of adults across the treatment cascade, but with an incomplete story that masks inequities among gay men and other men who have sex with men and the trans community. Now you can see the value of the whole story. Interventions will never be well targeted if you measure only the yellow. You need the whole picture. And that's what we are saying here. Traditional methods alone will not get us to any of these targets. We need to see the demand side and the supply side. What is the government and the healthcare provider saying, and what are we saying? So we need to get to the whole data story. How will we know what we need to change or where we need to intervene before 2030? It is impossible to know without both supply and demand side. Traditional M&E systems do not adequately integrate community data as part of the data story to effectively design and target interventions. So I would like to say that then community-led monitoring is a critical innovation, health innovation tool in our arsenal. And end on this slide. Yes, I know my time is up. Until the lions have their own historians, the history of the hunt will always glorify the hunter. And this was by Chinua Achebe. Thank you very much.